All right, well, it's 8 a.m. Welcome everybody to Department of Medicine Grand Rounds. And today we're going to learn about Sjögren's from Dr. Sara McCoy. To introduce Dr. McCoy, we have Dr. Christy Bartles, the Division Chief of Rheumatology. Christy?
Thank you. It is my immense pleasure to introduce Dr. Sara McCoy this morning as today's Grand Round speaker. Dr. McCoy received her bachelor's in biology from the University of Michigan, her MD from Case Western Reserve University School of Medicine, and she completed her internal medicine at the Mayo Clinic, and then completed her rheumatology fellowship at University of Michigan. We were lucky to recruit Sara to the University of Wisconsin in 2016, and in just that short time, she has accomplished a tremendous amount of she secured K funding, which is career development funding. She started the 7th U.S. Sjögren clinic, and she completed her master's in clinical investigation. And fun fact, she will be defending her PhD thesis tomorrow. So Sara, or within this month, and Sara will be completing that PhD very soon. Sara leads highly innovative research in basic and translational research. She's investigating the epidemiology and the pathogenesis of Sjögren's to target novel therapeutic pathways. She is refining the pathogenesis of Sjögren's through minor salivary gland mesenchymal stromal cell immunobiology, which is a mouthful and a really impressive body of work that she's doing, having gotten launched to this independent line of work, having worked initially and leveraging mentorship with Dr. Jacques Gallipeau. Sara's research is critical and has been described as cutting edge from people across the country and at the National Institutes of Health. And they really highlight that given the paucity of treatments, this is a really necessary area of research. Sara is focusing also on epidemiology and has investigated gender disparities, noting the fact that Sjögren is a 20-to-1 female to male disease, and she's had pivotal findings looking at the role of estrogen and reduced cumulative estrogen exposure as a risk factor. She has 15 published manuscripts and an invited book chapter on Sjögren, and she has co-authored the Sjögren Clinical Practice Guideline for Pulmonary Manifestations of Sjögren's. Her national reputation has also led her to be an invited reviewer for the National Institutes of Health and for the American College of Rheumatology abstracts. Sara's been invited to present at national and international meetings, including the American College of Rheumatology, the International Sjögren's Syndrome Society, and the Sjögren's Foundation. And recently, Sara won a Sjögren Foundation award for her research. In addition to all of that, Sara continues to inspire our learners, our fellows, and everyone around her with her energy and her expert knowledge. And with that, please welcome Dr. Sara McCoy with her presentation, Sjögren's Beyond the Basics.
Thank you so much, Dr. Bartles. That was a glowing introduction, and I only hope I can provide a presentation that matches that sort of introduction. Welcome, everyone, friends and colleagues. I've received some really fun messages and puns this week about you looking forward to this presentation, and I do hope it's engaging and interesting to you. With that, I'll get started. Here are my disclosures. Today, what we'll do is we'll start off with talking about the epidemiology and history of Sjögren's. We'll move on to a discussion about the pathogenesis. We'll talk about the diagnosis, and then we'll move on to cases because I think that's a little more engaging. By the end of this lecture, I expect you to be able to describe the pathogenesis of Sjögren's, identify patients who might have lung or GI-related Sjögren's manifestations, and you'll be able to manage oral dryness manifestations. I do expect the third to be widely applicable to all of you because either you know someone who has severe dryness or you have patients who have severe dryness, so this should come in pretty handy. So let's start off with some changes. The first change is the nomenclature of Sjögren's itself. So this was just brought up a few months ago. Sjögren's syndrome used to be the name. It's being changed to Sjögren's disease. Here in the United States, Sjögren Foundation is spearheading this. In Europe, they're trying to do a more informed and structured approach with a consensus panel, which I'm lucky to be part of. So that nomenclature may shift even more, and it may be divergent between the United States and elsewhere. And the reason they're doing this is because syndrome denotes an amalgamation of symptoms associated with morbidity with an unclear unifying pathogenesis, which clearly isn't the case in Sjögren's because many of us have been working hard to define a clear pathogenic background. So what is Sjögren's in the first place? It's oral and ocular Sicca due to chronic inflammation of the lacrimal and salivary glands, or exocrine glands in general. So it's an exocrinopathy. And as a quick reminder, where do your glands live? Well, your lacrimal glands live on the outer corner of your eyes. And in this picture, you can see that. And on the inner corner, you can see where the draining duct is. Your major salivary glands live right in front of your ear, and they extend to the angle of the mandible on both sides. That's the parotid. Your submandibular are those glands right below the angle of your jaw. And then your sublingual glands live right below your tongue. So we discussed the Sjögren's nomenclature change, but there are more changes occurring. We used to say primary and secondary Sjögren's, where primary Sjögren's is Sjögren's alone without a clear coexistent autoimmune disease. And secondary Sjögren's used to be Sjögren's plus rheumatoid arthritis or Sjögren's plus lupus. And that sort of has fallen to the wayside because secondary denotes it's not as important. And many patients who have severe dryness would argue that the Sjögren's portion can be just as important as the lupus or the rheumatoid arthritis portion. So that's moving towards overlap. And actually, this is part of that reimagined consensus study that's going on. So right now it's overlap Sjögren's, but that may also change. This is right now a shifting ground. Otherwise, other than the nomenclature changes, nothing else has changed significantly. So Sjögren's causes the dry eye and dry mouth, as we discussed, and exocrinopathy, but around 2/3 of folks have extraglandular involvement. So I want you to consider the patients who you see in specialty or general medicine who could have organ involvement and have severe dryness as seen in Sjögren's. And this is something that you should be aware of. And the reason is because many of these patients are misdiagnosed initially. So you can be the frontline person who recognizes a Sjögren's patient in your clinic. And I have received many referrals from primary care as the first place of recognizing Sjögren's. So that's really neat. So what can Sjögren's do? Oh, it can go anywhere and do anything. So it can affect the central nervous system. It can actually present very much so like MS, and it can be very difficult to tease out. I was going to present a case on this, but I thought that it wouldn't be as broadly applicable. It can cause a CNS vasculitis. It can affect the peripheral nervous system very commonly. It can lead to axonal neuropathies. It can lead to really interesting ganglionopathies, small fiber neuropathies. It really has a penchant for the nervous system. It can involve the lungs, which we'll talk a little bit about later, so I'm going to move onward. It commonly affects the kidneys, so we know that Sjögren's is a common cause of RTA. It can cause a glomerulonephritis akin to lupus. Nephrolithiasis, it's something that we screen for in all of our patients. Commonly, it affects the joints, leading to something akin to rheumatoid arthritis, but typically isn't erosive. So the joints aren't, the bone isn't actually damaged in Sjögren's, although everything else looks like rheumatoid arthritis. So if we see that the bones are actually demonstrating erosions, typically we think, well, maybe it's not as much Sjögren's, maybe it's more rheumatoid arthritis or an overlap. It commonly affects the gastrointestinal tract, and we'll go over some of these later. And then it also affects heme. It can cause cytopenias as well as an increased risk of lymphoma. So here is a chart showing the relative risk of malignancy in Sjögren's compared to healthy peers. And we can see that non-Hodgkin's lymphoma has about a 14-fold increased risk of malignancy than the general population. And actually in a study I just submitted, we showed that Sjögren's patients target effective treatment of non-Hodgkin's lymphoma or prevention of non-Hodgkin's lymphoma as one of their top desires for new therapy development. So this is a major problem. Now, not all Sjögren's patients are the same, right? So there are certain biomarkers we can look at to risk stratify these patients. So let's move on to a fun portion. Who doesn't like a little bit of history? It's so interesting. So in 1888, Dr. Haddon described a 65-year-old female who had severe dry mouth. She had a tongue that was red and so dry and cracked in all directions, it looked like crocodile skin. She was unable to swallow. She had no tears to cry. And she was treated with a tincture of jaborandi, which is also pilocarpine. And this is when the term xerostomia for dry mouth was coined. In 1888, Dr. Markowitz described a 42-year-old farmer who had painless symmetric swelling of the lacrimal and salivary glands. He had dry eye and dry mouth, and unfortunately, a year later, he died of peritonitis. And on autopsy, he had swollen major salivary glands with inflammatory cell infiltrate. This is when the term Muckowitz syndrome was coined. And we know that Muckowitz syndrome now refers to lacrimal and parotid gland swelling, and it's actually more likely this gentleman had IgG4 disease, but it can be caused by tuberculosis, sarcoid, and lymphoma as well. In 1933, Henrik Sjögren described 19 women with dryness and 13 had rheumatoid arthritis. Marie Sjögren was his wife and an ophthalmologist and worked as a collaborator. I'm trying to get through this presentation, but I will need to take a sip of water here. So who gets Sjögren's? Women more than men in a 9-to-1 to 20-to-1 ratio. The average age of onset is 56 years old. And there's variable estimates of how prevalent. Most rheumatologists think it's around 1%. However, this range goes all the way up to 3%. And that's because we think it's under-recognized in the general population. We think that, pardon me, we think that it's under-recognized because dry eye and dry mouth is so common, and these patients are seen in their ophthalmology clinics or in dental clinics and are never referred to rheumatology for diagnosis. The other trick is around 50% of these folks are initially diagnosed as lupus or rheumatoid arthritis, and it only becomes clear later in their disease that they have Sjögren's. As people age, the prevalence of Sjögren's increases. The other interesting feature of Sjögren's is the pathogenesis. So it is the most female predominant systemic autoimmune disease, with a ratio up to 20-to-1 female to male, more commonly around 9-to-1 female to male. And the other interesting component is that we know that these patients develop autoantibodies, usually anti-SSA antibodies, 20 years before onset of Sjögren's. And they get onset of Sjögren's around the time of menopause. I'm sorry. So the question is there something about hormone shifts that leads to onset of Sjögren's around the time of menopause? To address this question, what we did is we generated a composite estrogen score that took 5 components associated with higher estrogen exposure through the life, like early menarche, high parity, hysterectomy, use of hormone therapy, and late menopause. We then utilized a cohort of Sjögren's patients and patients who were dry but didn't have Sjögren's. And we looked at the odds of Sjögren's with increasing composite estrogen scores. And what you can see is that increased estrogen is associated with lower Sjögren's disease. And this occurred in a dose-response relationship. This indicates that potentially estrogen is protective. And this is an ongoing study. And we're actually working with Marshfield right now to, to perform a population-based study to follow this up. So what's going on in Sjögren's? Let's take a look at the pathogenesis here in a zoomed in scale. On the left-hand side, you see a normal salivary gland. On the right-hand side, you see Sjögren's salivary gland. And what you can see are dark purple spots, which are lymphocytic infiltrates with CD4 positive T cell predominance. And we also know living in this Sjögren's salivary gland are high levels of interferon gamma. And the higher the level of interferon gamma, the greater the association with that risk of lymphoma that we talked about earlier. So here is a zoomed in, probably CD4 positive T cell predominant lymphocytic infiltrate. And you can see all the purple dots, which represent lymphocytes. And living somewhere in this salivary gland are mesenchymal stromal cells. So I will tell you a little bit about how our group, pardon me again. Okay, I'm going to pause and self-treat because I am so dry. And those little nuggets I showed you earlier probably gave me a cold. This is an area of active area of research. And I'm going to tell you a little bit about how our group proposes MSCs might contribute to inflammation of the salivary gland. Mesenchymal stromal cells modulate the immune system. And in addition to a multitude of innate immune system interactions, MSCs impair CD4 and CD8 positive T cell proliferation through paracrine and direct contact. MSCs can also inhibit the generation and function of Th1 and Th17 cells while promoting Th2 and Tregs, which is really interesting because Th2 cells are more anti-inflammatory, so they have less interferon gamma, TNF alpha, and more IL-10. They inhibit antibody production and B cell proliferation. We previously discussed the anti-inflammatory effects of MSCs on the immune system. But MSCs can also have pro-inflammatory effects through expression of major histocompatibility class 2, MHC class 2. And they can act as an antigen presenting cell. So that's really interesting. What's even more interesting is that interferon gamma can amplify both the pro and anti-inflammatory effects of the MSC. So interferon gamma can increase HLA-DR, and it can promote those sort of anti-inflammatory effects that we showed on the last slide, wherein we have inhibition of T cell proliferation and B cell proliferation. So I wanted to know how local glandular interferon gamma affects Sjögren's disease salivary gland mesenchymal stromal cells. And to do this, we did a series of studies that right now are under review, and I think we'll have published pretty shortly. And we found, and this is sort of the synopsis of our research here. So we think that local interferon gamma promotes expression of HLA-DR and potentially allows these MSCs to act as antigen-presenting cells. Interferon gamma stimulates the salivary gland MSCs to produce chemokines that increase CD4 positive T cell chemotaxis. And this sort of potentiates a positive feedback loop involving CD4 positive T cells and interferon gamma production. So this pathophysiologic response, interferon gamma, in salivary gland resident MSCs is suppressed with the application of ruxolitinib, which is a JAK1 and JAK2 inhibitor. So we describe a biologically plausible physiologic response to pathologic interferon gamma in salivary gland MSCs. It's potentially treatable with ruxolitinib. And that's really exciting. And so we're going to go forward with this and study ruxolitinib further in Sjögren's. Genetics also play a role. So we know on GWAS studies that there are ties to HLA-DR, HLA-DQB1, and HLA-DQA1. And there is also associations with components of the innate immune system, T cells and B cells. No twin studies have been done, so it's still unclear the level of genetic contribution of some of these genetic ties. So how do we diagnose this disease? So we said at the beginning that Sjögren's syndrome presents with dry eyes and dry mouth, and that's true. The problem is that 30% of the population has dry eyes and dry mouth at some point in their life. And so how do we tease out when Sjögren's is present, which is an autoimmune cause of dry eyes and dry mouth? So we start off with defining, does the patient have dry mouth? We're looking for a total score of 4 to fit classification criteria. And as a reminder, classification criteria are used for studies, not diagnostics. However, these classification criteria provide a very convenient guideline because they show us that Sjögren's needs to have dryness and evidence of immune system involvement. So the first thing we can do is a Schirmer's test, wherein we measure the wetting of tears on a tear strip. And so you can even see here, there's a little line. And we know that 5 millimeters or less of wetting on the Schirmer's strip is consistent with dryness. We can also perform an ocular staining score. And to do that, I refer the patient to ophthalmology because it requires a specialist and a corneal specialist who specializes in dryness to do the lissamine green and the fluorescein staining for that. The next thing we can do in the bedside, this is right on my counter in the clinic, is we can take a scale and measure how much drool a patient produces in 5 minutes. And that's called an unstimulated salivary flow. And if either the Schirmer's or the unstimulated salivary flow is abnormal, then you know that they're really dry. And already you're increasing your pretest probability of having Sjögren's. The next thing we need to do is to establish, is there an autoimmune component to this? An easy way to do that is to order an anti-SSA antibody or an anti-Rho antibody. And this is very specific for Sjögren's. But unfortunately, around 30% of folks will not have an SSA antibody. And in those patients, we need to do a labial salivary gland biopsy. So here's a picture of the labial salivary gland biopsy. And in these, we perform something called a focus score, and it's the amount of lymphocytic infiltrate, the number of foci of lymphocytic infiltrates in 4 millimeters squared. So there are alternative clinical criteria. So I look at a patient, and if they have both a rheumatoid factor and an ANA, that's another sort of clinical hint to me, maybe that they have Sjögren's, although not meeting classification criteria. Other things we can do, many of you use ultrasound. I use ultrasound too. Here on the left, you see a Sjögren's gland in comparison on the right with a normal parotid gland. And what you can see is the normal parotid gland is homogeneous. It is nice and gray and the same throughout. On the left, you see a Sjögren's salivary gland. And you can see these hypo or anechoic lesions with a lot of hyperechoic lines. It kind of looks like Swiss cheese. And that's what I see in a very typical Sjögren's salivary gland. So let's move on to cases. This is a 66-year-old female. In 1973, she was diagnosed with lupus at the time of the birth of her first child. And this is very typical of a Sjögren's patient. So initially she had very severe onset, diagnosed with lupus. This was ultimately revised to Sjögren's. In the 2000s, she had interstitial lung disease diagnosed. And here's an image of that. And this looks very consistent with LIP. In 2018, she developed increased shortness of breath. And in 2019, she established at the University of Wisconsin. At that time, she had a positive SSA and SSB, and her component was normal. Her Smith RNP was normal. Rheumatoid factor was positive at diagnosis, but had turned negative. She previously had very high positive immunoglobulin levels, but this had normalized, and her antiphospholipid antibody studies were normal. On presentation, her FVC percent was 81%, and her uncorrected DLC was 58%. And then she had a CT chest done, and this is her CT chest. And on biopsy, she had small foci of active fibrosis, not typical for UIP, little alveolar parenchyma present, and that's clearly not a surprise from this imaging. She had relatively homogeneous interstitial expansion reminiscent of NSIP, and occasional disrupted polypoid clumps of granulation-like tissue, suggestive of possible organizing pneumonia. And so working with pulmonology, we've been treating her. We started initially with prednisone and mycophenolate, and she couldn't tolerate the mycophenolate, so we moved on to myfortic. She also couldn't tolerate that, so we gave her rituximab, ultimately added hydroxychloroquine and azathioprine. And we initially thought that she'd sort of stabilized, but actually we were just communicating about her, and her PFTs are unfortunately declining again. And so this case highlights some of the difficulties in treating Sjögren's and how severe the lung disease can be. So up to 20% of Sjögren's patients have pulmonary involvement. And some studies show even up to 65%. So what things are we looking at here? One is zero trachea, which is due to their severe dryness, and that's in up to 61% of folks. They also can have bronchiectasis, bronchiolitis, bronchial hyperresponsiveness. And I'd like to say that hyperresponsiveness is akin to asthma, but it's not related to eosinophils. More desiccation and hyperreactivity due to desiccation, like what I'm experiencing right now. A large number of individuals with unknown cause of ILD will have Sjögren's. So ILD is seen in up to 20% of folks. And many Sjögren's patients will have nodules, which we'll talk about a little bit more later. So let's zoom into ILD, like this patient. So what kinds of ILD can these folks get? They can get NSIP, UIP, lymphocytic interstitial pneumonia, and actually this is pretty common among Sjögren's patients, so that if I have an LIP patient, my index of suspicion is very high for Sjögren's and organizing pneumonia. And so the NSIP can occur in 61% of the ILD cases, UIP 16%, LIP 15%, and organizing pneumonia 7%. So other things can happen. So we talked about those nodules. Lymphoma and amyloidosis are very common in Sjögren's. And so if you have pulmonary nodules that are enlarging over time, you probably need to proceed to biopsy. And so what has all this led to? So I was fortunate enough to be invited to participate on the expert consensus panel for this. And the problem is that Sjögren's is very common, but unfortunately we frequently catch it at the back end. The patient already has ILD and is symptomatic. And we ideally would want to monitor for progression before they become symptomatic or severe. And so these are the recent screening guidelines that were published. And what they show is that even in asymptomatic Sjögren's patients, we should now be ordering a screening chest x-ray and PFTs on everyone. If they have symptoms, we proceed to CT chest. So this is why pulmonology colleagues, I've been sending a lot of patients to get PFTs because it's updated guideline. And so forgive me, but I've been referring quite a few to complete their recommended new screening. So let's move on to case number 2, which is gastrointestinal involvement. So this is a 39-year-old female. She presented to rheumatology in 2016. 2 years prior, she'd been diagnosed with inflammatory arthritis. And she had a positive CCP, ANA, and SSA. And this very nicely would demonstrate an overlap Sjögren's patient because CCP is very specific for rheumatoid arthritis. So I really thought she was largely rheumatoid arthritis. And then she also had anti-SSA antibody. She wasn't really dry. She had overlap Sjögren's, but I wasn't addressing the Sjögren's as one of her primary issues at that time. I treated her with hydroxychloroquine. Oh, previously she was treated with hydroxychloroquine. On exam, she still had polyarticular synovitis. And her other labs showed an ANA of 1 to 320, the CCP and SSA, an IgG greater than 2000, and negative ANCA double-stranded DNA and rheumatoid factor. So I started her on methotrexate. And then because she didn't fully respond, I transitioned her to leflunomide. In 2018, I ultimately started abatacept. Around that time, she was diagnosed with a cheek mass that was called an abscess. And if you might remember what can happen with Sjögren's, where are the major salivary glands? They're these guys that live right in front of the ear, and they can become very swollen and can get infected. She had severe chest pain as well. On her labs, we saw new elevation of her LFTs with an ALT bumping up to 148 and an AST bumping up to 123 with a normal alpha phos. We proceeded to biopsy, and on biopsy, it showed inflammatory infiltrates noted in all of the pleural tract composed of lymphocytes, plasma cells, and scattered eos. An abundance of lobular inflammation with clusters of lymphocytes and plasma cells identified with clusters noted near central veins. Trichome staining revealed portal fibrous expansion secondary to the inflammation. She was started on azathioprine and budesonide and or prednisone. So akin to pulmonary manifestations, gastrointestinal manifestations are very common. So xerostomia, the hallmark of Sjögren's, occurs in more than 95% of our patients. Patients frequently have burning mouth or glossodynia. This is caused by dryness, inflammation. You can get Sjögren's associated neuropathies that affect the tongue. Lichen planus is something you should always consider in these cases. Sometimes with the burning mouth, you can just change their toothpaste or improve their salivary flow, and that might help. I've had really refractory burning mouth, and in those cases, I've actually found topical clonazepam can be of benefit. You have to get this compounded, but when desperate, these patients are very symptomatic, and so I really try to find ways to make them feel better. Dysphagia occurs in 30 to 80% of folks. Studies are conflicting regarding the source of the dysphagia. Most authors find no relationship between dysphagia and salivary flow rates. Esophageal manometry shows that the upper esophageal sphincter may be reduced, and there are non-specific motility abnormalities associated with Sjögren's, which has been found in some studies, but not others. So some studies have found things like aperistalsis, tertiary contractions, non-peristaltic contractions, and decreased contractility. Also, the lower esophageal sphincter pressure may be low. In other words, there's a host of possible contributing factors, but we haven't found anything definitive to explain this. Heartburn in 20 to 60% of folks. Dyspepsia can occur commonly. This may be secondary to gastritis with reduced acid production and the presence of antiparietal cell antibodies. It's typically not related to H. pylori. And celiac disease is actually common in this population. So let's move onward. LFT abnormalities, as we saw, in up to 40% of folks. And so in these situations, usually we do the usual, which is to evaluate for drugs and non-alcoholic fatty liver disease. I always make sure every Sjögren's patient I see, I screen for hepatitis C. And the reason is that hepatitis C causes dry mouth, just like Sjögren's, and actually can cause identical salivary gland findings. So a hep C patient will have exactly that ultrasound finding I showed you before. If you were to biopsy it, you would see inflammation that on pathology does have some differential features from Sjögren's, but certainly I always want to keep this in my mind. Autoimmune hepatitis occurs in 5%, and PBC occurs in less than 5%. So I would like to say that in folks that have a high ALK class or Billy, I usually order an anti-mitochondrial antibody to screen for this. So although it's rare among Sjögren's patients, some studies say that Sjögren's occurs in about a third of PBC patients. So in your patients who have PBC, it's really important to keep a high index of suspicion for Sjögren's. And then Sjögren's as an exocrinopathy has high rates of exocrine insufficiency. Pancreatitis occurs rarely. What else can occur? Atrophic gastritis in 20 to 80% of those who have undergone endoscopy. Gastroparesis in 30 to 50%. And we think this is related, again, Sjögren's has a penchant for nerves. And so we think that this is a reflection of a neuropathy. And there are a whole host of other things, right? Non-specific abdominal pain, constipation, chronic diarrhea, celiac, GI vasculitis, and sclerosing mesenteritis all can occur. And I have a sclerosing mesenteritis patient. Also, I was debating presenting today, but we have so much to go over in so little time. I just couldn't quite squeeze it in. So how important are these GI manifestations? Well, this is a really neat study that we were able to do where we looked at oral and esophageal symptoms and how it affects quality of life. So here on the left, you can see frequency of symptoms. So dysphagia from monthly to daily, trouble speaking from monthly to daily, mouth ulcers and sores from monthly to daily. And then we have systemic manifestations that usually rheumatologists and other providers would put as their top target of therapy. Things like vasculitis, purpura, petechia, or cryos, neuropathy, or interstitial lung disease. And if you actually look at what the patients care about, when you look at their quality of life outcomes like memory and concentration, activities of daily living, mood, and relationships, on the bottom axis, we see the odds ratio of this being negatively affected. We see that dysphagia causes functional interference with an odds ratio of 4.5-fold those who don't have symptoms of dysphagia frequently. And so what this study showed us and highlights really nicely is that the oral esophageal symptoms that our patients with Sjögren's experience impact quality of life significantly more than those organs that are involved that we typically target for treatment. And so because of this study, actually, I now screen all of my patients with dysphagia questionnaires, and I try to identify it earlier and refer them on to things like swallow or speech therapy. All right, so let's get on to case number 3. This is a 45-year-old female who presents with dry mouth and burning tongue. She tried biotin products, so these are mouth wetting agents. Another product is mouth coat, but they're wetting agents. So you just apply them to the mouth or swish with them or a gel, and it seems to alleviate the symptoms. She gives a history of having dental caries as a child, but this last year she's had progressive increase in caries. And she brushes and flosses twice a day. She is somebody who has very good dental hygiene. On her lab, she has a positive anti-SSA antibody, an ANA, and a rheumatoid factor. So we did an oral exam, and these are her teeth. And actually, I asked to take this picture before. She had all of her teeth removed, and she just underwent dental implant surgery for all of her teeth. And this is despite good oral hygiene. We also saw cracking at the corner of the mouth. And this angular cheilitis is something that we'll talk about and is really important to examine your dry mouth patients for. And then we also saw this. And so what we see here are three very common Sjögren's manifestations, but also manifestations of severe dry mouth. Let's walk through them. So first thing we see are the cavities, right? And this is very obvious. You know when your patients have poor dental hygiene, and it's something we can address, and we'll go through how to do that. So if the cavities are due to dryness, there are many things that we can do to help prevent caries. When we see angular cheilitis in dry mouth patients, it actually can reflect candidiasis. And so when I see angular cheilitis, I'll immediately reflex to treatment with an antifungal agent. And then on the right-hand side here, you see a mouth and a tongue that has depapillated or then had some papillary atrophy. And so a normal non-dry patient, you should see the tongue papilla very clearly. Sometimes I'll see fissuring as well. And all of this or a red tongue can represent erythematous candidiasis. And that can occur with dry mouth. It can also occur with uncontrolled diabetes, iron deficiency anemia, or B12 deficiency. So we can recognize this, so the patient will have these findings on examination, but they also may say that, oh my goodness, my dryness is way worse than it used to be, and I now have a bleeding mouth. And so recognition of this erythematous candidiasis is really important because you can make an immediate intervention that improves their quality of life. All right, so let's get down to the treatment of these manifestations of dry mouth. So how do we treat dry mouth overall? Avoid mouthwash or rinse with astringents. People love using mouthwash with alcohol in it. That is not good. So I advise them to avoid that. I recommend my patients use sugar-free gum, candies, or lozenges, xylitol being preferred. These are gustatory agents, so they stimulate saliva production by chewing. And actually, we use paraffin gum for to stimulate saliva in our clinical trial patients to measure stimulated salivary flow. So just the act of chewing or sucking on something makes saliva. They can use wetting sprays or agents for short-term relief. So this is what we talked about before. So the patient had tried biotin products. There are a ton of different products you can try to just wet the mouth. The other thing you can do, I have a lot of my patients take a teaspoon of an oil, like a coconut oil or an olive oil, and 8 ounces of glass of water, and then swish it in their mouth. And that oil added to the water will coat the mouth and act as a moisturizer. And the last line are sialogogues. So let's rewind and go back to the beginning of the talk. Remember that very first patient in 1888 was treated with pilocarpine? That is still what we use today. So we've made very little progress in over 100 years. And that's one of the reasons why we're focusing on developing new treatments for the disease. Next, we have Candida treatment. So how do I treat Candida in patients? And so I've actually, my nurses kind of make fun of me, but I've built a tongue compendium where I take pictures of all the interesting tongues I see on a day-to-day basis. And I've only shared a few with you, but if you would like to see more tongues in my tongue compendium, I'd be happy to share them. So on the left here, you see a fissured tongue. This is very common in Sjögren's. And on the right, you see another example of a depapillated tongue. And this one is a little bit more erythematous. So in both of these cases, especially if they note increased dryness or increased burning, I would proceed to treatment with an antifungal therapy. My go-to is clotrimazole lozenge 5 times daily, or my conazole 50 milligram mucoadhesive tab. I do not like to give nystatin. And the reason for this, it has a high concentration of sugar and actually promotes dental caries in patients who are dry anyway and at risk for dental caries. Some patients have really resistant candidal infections, and I have to use an oral fungal agent to treat them. The last thing I want to talk about is caries prevention. So the top thing we have to fight or combat caries is nightly use of prescription strength fluoride toothpaste. I try to prescribe all of my patients prescription strength fluoride toothpaste. Most of my patients come to me with a lot of caries, and I will tell you only a small percentage of them have been given prescription strength fluoride by their dentist. The next thing we do is applied fluoride varnish. So most of my patients, again, are seeing the dentist usually every 6 months to every year. And many of them are not getting their fluoride varnishes. So I write out for them, ask your dentist for fluoride varnishes at your dental visit. Additionally, our patients who have dry mouth and caries should be seeing the dentist every 3 months, not every 6 months. And lastly, promotion of saliva can be protective. So we know that the salivary glands produce saliva that's bacteriostatic. And so just production of saliva is bacteriostatic and can reduce the risk of those caries. Now, unfortunately, in Sjögren's, even if you make more saliva, the saliva is still not normal. So we know that its bacteriostatic efficacy is below those of a normal patient's. And here's another neat little tip. So clearly some of our patients are using whitening toothpaste. Avoid that because it's abrasive. And then actually you want to use rounded bristles. So not squared bristles. And this can also help prevent dental caries. If a patient consumes an acid, like, for example, they're having vinegar on their salads, or they like their Mountain Dew, right after they consume the acid, they should take a teaspoon of baking soda, mix it in 8 ounces of water, and then swish that in their mouth. And that should neutralize their pH and also help prevent cavities. So what can we do to treat the underlying cause of this, the driving issue? What can we do to treat Sjögren's? Well, we actually have nothing to treat Sjögren's right now. There are no disease-modifying therapies. However, there are multiple clinical trials that are ongoing that look promising. And so the Sjögren's community right now is preparing for hopefully having a drug that is disease-modifying. And this is a big deal because many Sjögren's patients, as we talked about, are underdiagnosed or misdiagnosed. And so we're trying to create a national movement to increase the recognition of Sjögren's because we are preparing for having effective therapies. And actually here at UW, we are one of the clinical trial sites for one of these drugs. So at this point, I think you should understand that mesenchymal stromal cells, which we are currently studying and so favor a little bit, might have a pathogenic role in Sjögren's disease, and it's understudied, and we would like to know more about it. We should screen Sjögren's disease patients with pulmonary function tests and chest x-ray at baseline and with any additional symptoms. GI symptoms are a major source of impaired quality of life in Sjögren's. And so ideally we should be addressing these and trying to intervene aggressively for them. And then here, I think a really neat takeaway is being aware of atypical manifestations of candidiasis, aside from just thrush that you're used to looking for in patients who have dry mouth. With that, I would like to put in a plug for my Sjögren's clinic. We are pretty busy seeing lots of Sjögren's patients, and we're really working towards advancing their diagnosis and treatment nationally as well. With that, I'd like to acknowledge my team. So this is Ilya and Maxwell, who are working away on research projects. Dr. Gallipo is my K mentor, and he has been really supportive. Something I'd like to say about mentors and physician scientists is that we have this great privilege to progress through our career and change what we want to do and be flexible. And I think that mentors are pivotal in allowing and supporting us to progress as physician scientists and to evolve. So I'm really grateful for the support I've received. I don't just have that small team. I actually have a huge base of mentorship and support. And so I'd like to thank all of my mentors, including Dr. Gallipo, Bear, Bartles, Lamming, Gagnon, And then of course my research team. And then also I'm thankful for all the support I've received through grant funding. And with that, I will take any questions that you might have. Thank you.
Great. Thank you for a wonderful overview. First question, is there evidence that polymorphisms affecting thymic selection are involved given the wide variety of apparent tissue targets?
That's a good question. You know, I don't think that we necessarily know at this time if that is involved, and actually I'm not aware of any research, but I'd probably pop right off of this talk and go research that myself. I'm not aware of
any. Another question, and maybe I missed this, you were talking about the gender bias for Sjögren's in the epidemiology. What about in underserved communities or minority communities?
So this is an area that we are trying to work on because it's a major deficit in Sjögren's. So Sjögren's is over 90% Caucasian. We have almost no studies on African Americans or Hispanic Sjögren's patients, and this is a major deficit that we're trying to address through the NIH. And there's a movement amongst us to dedicate our studies to focus on African American and underserved populations because they are underrepresented in our studies. It's a major deficit, and actually it clinically is a major deficit because when we see an African American who we suspect has Sjögren's, frequently they're told that they have lupus or something else because they don't meet our criteria or a typical definition of Sjögren's. But we actually don't know how Sjögren's might manifest differently. And so yes, we don't know, and it's a growing area of research. We're trying to target that population.
Yeah, and I was going to ask whether it's under-recognized in those populations.
Yeah, I mean, it's very likely because this is a theme in Sjögren's is that it's under-recognized. So yeah, more research needs to be done, and it's a major deficit that we're having a lot of trouble addressing, and we need to.
Okay. Question from Ann Mish. Given the dysregulation of innate immune signaling mediators like STAT3, et cetera, in Sjögren's, do you know if there's an altered susceptibility to intracellular organisms such as mycobacteria in patients with Sjögren's?
So we don't have any evidence of increased susceptibility to intracellular bacteria. However, we do believe that viruses potentially trigger the disease or the patients are predisposed to them. So we know that these patients have higher rates of hepatitis C and HIV and CMV. So there's sort of these cytotropic viruses. And we find that Sjögren's patients in their tissue have higher rates of these viruses than non-Sjögren's patients. But it's a chicken or the egg, right? So does a virus trigger it, or is there something aberrant in the Sjögren's immune response that allows for these viruses to persist? We don't know.
And then given how many different tissues and organs are affected, is there an identified common antigen that unifies all the different target organs?
So that's interesting. So that's a study that I'm working with Dr. Shalef on, is finding new antigens with autoantibodies. So the most common one is the anti-SSA or anti-Rho antibody, and we know that we can find that in saliva, in gland tissue. I'm not aware that we found it in lung tissue or liver tissue. So there's not an antigen that we found sort of unifies all of the organs that are involved. However, when you have B cell and T cell activation in general, right, you can have off-target sort of effects because it's systemically and peripherally present. But we don't know about those other tissues in the presence, but usually it's SSA antibody, and then we're working on finding new antigenic targets of these autoantibodies that are present in Sjögren's.
Then from Steve Barzy, as with many diseases that have a prodromal period and genetic association, there's often a multi-hit process. You sort of alluded to potential of viral infections that can lead to manifestations of the illness in some, but not others. Have there been more epidemiologic studies that have identified these other potential triggers?
Yeah, so viruses are the main one at this time. We have some interesting epidemiologic data that suggests, and I would not put this out there, but suggests that smoking actually might be protective, which is interesting and akin to some other GI autoimmune diseases, right? And then also obesity seems to be protective potentially in Sjögren's, but that is something that is ongoing, and we are going to hopefully publish at some point in the near future.
Great. And what's the natural history of Sjögren's? Do patients die with Sjögren's or of Sjögren's?
So Sjögren's is not in itself associated with increased risk of mortality. So they will die with Sjögren's in most cases. The exceptions are males, if they have vasculitis, if they have really low complement, or if they have lymphoma, they're increased risk of mortality due to Sjögren's.
Great. Okay. And then interesting question. Do these patients, if you, the one you show where you take all the teeth out, do they tolerate dentures?
Oh, denture, no. And this is so sad. So I have a form letter that I give them trying to get their dental care covered under their medical insurance. Because dentures already are increased. If you don't clean them appropriately, right, you can get fungal infections secondary to dentures. So they have huge problems with dentures, with Candida infections. And so the other problem is that they're already so dry, they get sores from their dentures. So implants are actually preferred in this population. But getting medical insurance to actually cover it is nigh on impossible. And I've gotten it successfully covered with one patient, but I've written probably 20 or 30 letters.
Yeah. Okay, great. From Miriam Shalaf, what is your approach for treating Sjögren's associated transaminitis? That's not primary biliary cholangitis, I presume.
Yeah.
It's ABC.
So as with most multi-organ rheumatologic problems, I work with a specialist, but budesonide, prednisone, azathioprine, mycophenolate are the typical go-tos. And they usually respond pretty gosh darn well, just like the patient we presented here. And we have excellent, as we know, hepatologists to work with too.
Great. Okay. Great. That is all the questions other than comments about the great talk. So thank you again for the insights into Sjögren. Looking forward to participating in trials of disease-modifying treatments. I think that's very exciting. And I'm going to have to change my nomenclature from Sjögren syndrome to Sjögren's disease. I got to get used to that one.
Yeah, well, it's still evolving. So
okay, stay tuned.
Yeah.
All right. Well, thank you, everyone, and have a great time.
Thanks, everybody.